Urticaria and angioedema. The initial lesion of urticaria is the wheal, which is superficial itchy swelling of the skin due to transient plasma leakage from the small blood vessels. When the plasma leakage extends to the deeper layer of the skin and the subcutaneous tissue, this condition is called angioedema. Some patients might be presented with the wheal only or with angioedema only, and sometimes the wheal and angioedema coexist together in the same patient. What is the pathophysiology of urticaria? Histamine is the most important mediator of urticaria. It is produced and stored in the mast cell. There are several mechanisms which will lead to histamine release after the process of mast cell degranulation. The first mechanism is immunologic, which is IgE mediated, and the second mechanism is non-immunologic, like in case of physical urticaria. This picture will show us the mast cell, where we have here in blue, these are the IgE receptors. When the antigen enters the body, it binds with IgE antibody on the receptor which is present on top of the mast cell. This will lead to degranulation of the mast cell and release of multiple mediators. After the process of degranulation and release of histamine from the mast cell, it works on the nerve endings, leading to itching or pruritus. And the main process here is its action on the blood vessels. It will cause vasodilatation, and then it will cause contraction of endothelial cells, leaving pores, which will lead to extravasation of plasma, leading to the formation of urticarial wheal. So this is actually what might happen. We have the IgE receptor on top of the mast cell, and then we have IgE antibody attached to the receptor on top of the mast cell. When the antigen comes, it will lead to degranulation of mast cell and release of histamine. It will work on the blood vessel, leading to vasodilatation and leakage of the plasma from the small blood vessels. If it is accumulated in the superficial layer, it will be called heaves or wheals. And if it is accumulated in the deep dermis and subcutaneous tissue, in this case we have what's called angioedema. So what is the classification of urticaria? Depending on the chronicity, we have acute urticaria up to 6 weeks, and we have chronic urticaria more than 6 weeks. The chronic urticaria might be spontaneous or inducible urticaria. Now, what are the causes of acute urticaria? In many patients, still idiopathic. And the second common cause is infection, especially acute upper respiratory tract infection. Some food and drugs, like the aspirin, non-steroidal anti-inflammatory, might cause acute urticaria. Now, for the chronic urticaria, as I said before, it might be a chronic spontaneous urticaria, which is idiopathic or autoimmune. Autoimmune chronic urticaria, here the antigen is not an external antigen, it is an internal antigen, which is anti-IgE antibody. So it will attach to the IgE on top of the mast cell, which will lead to release of histamine after degranulation of the mast cell. Like in cases with different autoimmune disorders, one of the most common causes is autoimmune thyroiditis or Hashimoto disease. Chronic infection also can lead to chronic urticaria, like chronic bacterial, the Helicobacter pylori, chronic parasitic, or even fungal infection. Pseudoallergen are non-allergic dose-dependent delayed-type hypersensitivity reaction, especially to food colorants and preservatives and taste intensifiers. The chronic spontaneous urticaria, we have here what's called physical urticaria. It is named according to the physical stimulus. So we have the cold contact urticaria caused by cold, delayed pressure urticaria by vertical pressure. We have the heat contact urticaria. It is elicited by the localized heat, solar urticaria, due to exposure to the sun and its ultraviolet and visible light. The dermographic urticaria. Here the dermographic urticaria, it's mechanical shielding force. The actual cause is unknown. The idea of dermographic urticaria is that when you scratch the skin, we have what is called triple response of Lewis. And the triple response of Lewis, we have vasodilatation with erythema, and we have edema. In cases of dermographic urticaria, we have more erythema and more edema. It will take the shape of the scratching subject or object to the skin. We have aquagenic urticaria due to exposure to the water. We have cholinergic urticaria, which is caused by increased body core temperature, like in some cases of severe physical exercise or spicy food or hot water. So sometimes the patient will feel a pricky sensation or even sometimes very small monomorphic small papules. We have contact urticaria. It is caused by contact with arteriogenic substance. Now, what is the clinical manifestation of the wheal? It is polymorphic, round, irregular shape, and itchy. There are central swelling variable in size, surrounded by reflex erythema. The itching is anaerobic in character, a fleeting nature or evanescent. It means that the lesion will appear and will disappear within from half an hour or 1 hour up to 24 hours. Some clinical variants are like polycyclic pattern with peripheral extension and central clearing and vesiculobullous variant. This is a classical picture of urticarial wheal. We have well-defined edematous swelling surrounded by reflex erythema, and we have different sizes of urticarial wheal, and as I said before, it will last within 1 hour to 24 hours. This is an example for annular lesion forming different annular lesion. When it binds together, it will form what is called the polycyclic pattern urticarial wheal. Now for the angioedema, it is non-pitting, non-pruritic, well-defined edematous swelling. The swelling here it will extend deeper in the deep layer of the skin and the subcutaneous tissue. We have pain rather than itching, which might be present in the wheal. Frequent involvement of mucous membrane, and this is the main danger because when it is involved of the mucous membrane, you have a danger of affecting the mucous membrane of the larynx, causing stridor and suffocation. And the resolution, it is slower than the wheal. The wheal, it will take 1 to 24 hours. In case of angioedema, it will take longer time, might be up to 3 days. These some cases where we have here the angioedema on the lips and the periorbital area. The clinical types, we have idiopathic angioedema with unknown cause. We have allergic angioedema, and this type is often associated with the urticaria with the different causes of urticaria said before. And we have angioedema caused by C1 esterase inhibitor deficiencies. This enzyme is very important for the complement system and the fibrinolytic system and other systems in the body. So when we have hereditary angioedema, in most of the cases we have family history, or when we have acquired angioedema due to either increased metabolism as in cases of lymphoproliferative disorders, or the formation of enzyme antibodies like in autoimmune disorders, we might have angioedematous problem. Urticaria vasculitis, it is other type or variant of chronic urticaria. The urticaria vasculitis, it is characterized by pruritic or burning or even painful raised superficial erythematous well circumscribed wheals. The individual urticaria lesion lasts frequently than 24 hours and they leave a residual transient hyperpigmentation. It is associated with some systemic manifestation, especially arthralgia and myalgia, and skin biopsy will reveal vasculitic changes. This is the picture of urticaria vasculitis. As you can see here, the bluish color of the lesions, and you might have post-eruptive hyperpigmentation, which is actually not present in the cases of ordinary urticarial wheals. Another variant, which is papillary urticaria, it is a typical response to the bites of different arthropods, including biting fleas, mosquitoes, and so on. The lesions are small, urticated papules, often surrounded by tiny vesicles and are so itchy, which will lead to excoriation, and if a secondary infection might occur, here the patient will need antibiotic application. It is kind of hypersensitivity reaction to the antigen in the arthropod. It is commonly present in summer. This is a picture of papilla urticaria. We have multiple monomorphic papules. It's very itchy. It is stopped by small vesicles, and sometimes when the patient just scratches the lesion due to extensive itching, it will lead to excoriation and the possibility of development of secondary bacterial infection. So how to diagnose a case of urticaria? The most important part is the history. History is very important. We should know everything about the patient, his style of life, his drug history, his medical history, his family history, and so on. We should know the onset of urticaria, the extension of urticaria, if it is associated with angioedema or not, and so on. Mainly the blood tests are done in cases of chronic urticaria. Acute urticaria, we don't need to do lab investigations. In chronic urticaria, we might need to do blood count, sedimentation rate, C-reactive protein, and the idea is just to search to exclude major internal condition. Stool analysis for Helicobacter pylori and for parasitic infestation. If we have a doubt about autoimmune disorder, we should do antinuclear antibody, thyroid test to exclude thyroiditis. The autologous serum skin test, it is done to identify the anti-IgE antibody or the autoimmune type of chronic urticaria. Screen prick test is sometimes done to measure the presence of IgE antibodies against a certain types of food. In cases of angioedema, complement C4 and C1 esterase inhibitor level and function might be done. The differential diagnosis, we have different differential diagnoses, like in cases of atopic dermatitis, the contact allergic dermatitis, drug eruption, erythema multiforme, the papules present during pregnancy, and the early condition of pemphigoid, sometimes you have urticated lesion. Now for the treatment, the most important point is you have to eliminate the cause. Whatever is the cause, we have to search for it, like the food and drugs, and should be eliminated. As a topical application, sometimes you might need to do calamine lotion. It is proved to be soothing effect on the skin and suppress histamine, which induce itching. For symptomatic treatment, the first line of treatment is antihistamines. Now we have two types of histamine receptor. We have H1 receptor and we have H2 receptors. H1 receptor is present mainly in the skin and to a lesser degree in the gastrointestinal tract, while H2 receptor is present mainly in the gastrointestinal tract and to a lesser degree in the skin. So for the treatment of urticaria, we shall start with H1 receptor antagonist. The first generation are called sedating antihistamine, and then due to the side effect of sedating effect which interferes with the lifestyle of the patient, they come up with the second generation. So we start with second generation like cetirizine, fexofenadine, disloratadine, and loratadine. Usually we start with the usual dose, and if we have no response within 2 weeks, we can duplicate the dose up to 4-fold. In some cases where the patient is complaining of irritability and inability to sleep, we might add at night one of the first generation molecule, which like the hydroxyzine or diphenylhydramine. In some other cases where the response to H1 antagonist is not so high, or we have some cases resistant to the systemic H1 antagonist, we might add H2 receptor antagonists like doxypen or cyproheptadine or the cimetidine. Immunosuppressive drug, which like the cyclosporin, are mainly in patients with immune urticaria. They are recommended only for patients with severe disease refractory to high doses of oral antihistamine. The oral corticosteroids are not indicated in cases of chronic urticaria because we might have problems with the systemic corticosteroids, the side effects of corticosteroids, withdrawal problems. So that's why oral corticosteroids are taken in short-term therapy within 3 to 7 days and should be withdrawn immediately, especially only in case of acute severe generalized urticaria unresponsive to antihistamine, and as I said, never indicated in cases of chronic urticaria. The mast cell stabilizer actually has no major effect in the urticaria. only in some types of cholinergic urticaria. The leukotriene inhibitor, which is montelukast, the idea is that when the mast cell degranulation occur, not only histamine, which is the main mediator, which will be released, but we have other mediators like prostaglandins, cytokines, and leukotriene. So they found that montelukast with anti-leukotriene or leukotriene modifier might help in some cases poorly controlled by the antihistamine. Recently now we have what's called biologic drugs. And the biologic drug which is indicated for the treatment of chronic urticaria not responding to the antihistamine is omalizumab. It binds to the free IgE in the blood, and it is they are unable to bind to receptor on surface and mast cell and basophils. They are only attached to the mast cell receptors. The angioedema, the main treatment in severe cases is subcutaneous epinephrine, which is adrenaline. But if you have contraindication like hypertension or ischemic heart problem, we might use corticosteroid injections, intravenous injection of corticosteroids. Of course, in severe cases, the patient should be admitted in ICU because, as I said before, it is very critical emergency condition which might lead to a fatal condition if it is not treated properly. In moderate cases, close monitoring is very important. Diphenylhydramine, which is antihistamine, intravenous or intramuscular injection. Corticosteroids, intravenous injection is very important in these cases. For the regional swelling, of course, as the epinephrine is mandatory, it is administered subcutaneously or intramuscular. And for the prevention of attacks of angioedema, administration of androgen derivatives like danazole or antifibrinolytic agents like tranexamic acid may be considered. Thank you very much.